think I know something about hypertension, and you certainly taught me a few things. So it was excellent. So thank you very much.
Thank you, Sue. Thanks.
Brenda Ridley, you have met earlier in our programming. Brenda is our CCCN president. She's also a partial load professor at Humber College. And she is going to speak on COVID-19. And her colleague, Lindsay Shields, is also a registered nurse who works at the University Health Network in Toronto. And Lindsay is also a critical care, cardiovascular care instructor. She teaches in both critical care and cardiovascular care at Humber and Sheridan College. So please join me in welcoming both of these two colleagues, and I will ask you to share your screen, ladies.
Alrighty, so just gonna get my slides started here. So first I'd like to start off by saying thank you to CCCN for this opportunity, and also to extend my gratitude to Lindsay. Lindsay and I have been friends and colleagues for many years, and part of the time I'm teaching at the college, I still work casually as a nurse at the Toronto Western site. So Lindsay is often my eyes and ears in the clinical environment about what she's seeing and what's changing and evolving. And when I think about when I started in cardiology in the 1980s, before we had portable and small technology, and just the leaps and bounds that we've made in terms of technology, levels of evidence and best practice guidelines. I can still remember squeezing nitro paste out of a tube and measuring it and putting those on people's arms. And our ECG machines had suction cups, and just, I think, as the expression goes, we've come a long way. So what we kind of wanted to do is dive into a little bit about COVID and the cardiovascular system. I truly believe there isn't anybody who isn't aware of COVID. Do want to start with just a really high level definition of it, and really focusing on sort of COVID and some of the current recommendations, and then talking about a specific case and the implications of COVID for healthcare professionals, looking again at STEMIs and certainly some of our anecdotal experience in the Toronto practice area, and sharing some statistics from Ontario. So based on our presentation, Lindsay and I have no disclosures. Boy, if I had a crystal ball and could go back in time, I know I would have bought some stock in some of the companies I've been privileged to work with, but who'd have thunk it? So we're going to be sharing latest evidence, really some of the impact on cardiovascular disease and COVID, some of the current standards. Briefly also want to touch on mental health, because I think that is a very important component around COVID and some of the vicarious trauma that healthcare professionals have experienced. And then Lindsay will be presenting an actual COVID patient presenting with STEMI and her experience in Toronto. So COVID, I don't think there's anybody in the world who actually has a radio or a television set, or, you know, you're active in any kind of social media platform. I think the amount of information about COVID has been phenomenal. I think things really changed on March 11th, 2020, when the World Health Organization declared COVID-19 as a pandemic. Some of the early literature coming out of Wuhan, which was often referred as the epicenter, or where we started to get case reports, certainly some of the early data that's been published back in February by Wang et al. Just demonstrated, they looked at 138 patients hospitalized with COVID. 16%, almost 17% of these patients developed arrhythmias, and just over 7.2% actually had cardiac complications. And again, a fairly small number, but this was the real life experience, and certainly looking at how does this translate from the initial Wuhan experience to what people are seeing in Europe, what people saw in the US and in Canada. And I started to kind of go through guidelines and information. I personally found it extremely overwhelming. I was very privileged to go to several COVID-related webinars. CCS did a number of webinar series as COVID continued to change and evolve. And I think we're still at, certainly in some ways, not kind of knowing yet what the long-term effects will be and how patients have been impacted. So really just going back to kind of where things all started from. Moving to the European Society of Cardiology, and certainly they've come out with some important information about COVID risk factors. And most people, when they hear COVID, think about it as primarily a respiratory disease, and people that had the profound hypoxemia, but also looking at the associated cardiovascular risk factors, the comorbidities, certainly the presence of cardiovascular disease. There's been information as well about ACE inhibitors in cardiovascular disease and COVID. Surprisingly, some early data to suggest that COVID and cardiac complications incident is higher in men than women. So again, they've come out with some sort of preliminary recommendations and kind of a jumping off point from a respiratory focus to also looking at a cardiovascular focus for COVID and certainly what we're seeing. They published this on June the 10th. A little bit of a busy image, but really kind of getting into the management of cardiovascular disease. And this is ongoing research that's being done with the ESC and really focusing on some of these inflammatory mediators and huge linkage to myocarditis. We know about Takotsubo's disorder. Now there's a name called COVID-SUBO. It's some new literature coming out about kind of almost that Takotsubo clinical presentation, but directly correlating to positive COVID presentation, the macrovascular endothelial dysfunction leading to acute coronary syndrome, heart failure, arrhythmias, and even myocarditis. And we are a quaternary referral center, and we do have the ability to, we're a regional cardiac and transplant center and respiratory center. So at the height of COVID, we did have patients on full life support with extracorporeal membrane oxygen, or what we call ECMO, to support these patients. So certainly in our sort of cardiac world and respiratory world, we did see certainly some of these things. Interestingly enough, Lindsay did speak with our heart failure team, and certainly I think we're still in the discovery phase of what does COVID exposure mean for long-term cardiac changes, what's happening within our heart failure patient population. I know there are research trials going on, looking at real life experience, certainly in Toronto. There's cross-Canada studies going on, and the ESC has a multi-country, multi-state trial looking at management of cardiovascular disease, so cardiac surgery, as well as non-ST and ST segment elevation clinical presentations. And certainly that will be ongoing work and very interesting to see what the data actually does reveal. Okay. Looking at certainly the American Journal of Medicine, Long et al. Again has published a little bit more information about COVID-19. Certainly risks, again, you look at some of the risks, again, things we associate with cardiovascular risks, so any kind of pre-existing renal disease, respiratory diseases with right heart implication and diabetes, and then certainly immobility and older age. And then tying that COVID risk piece into what we're seeing with cardiovascular complications. So the STEMIs, the myocarditis, and sometimes the overplay between how patients clinically present and getting that differential diagnosis, heart failure and cardiomyopathy, and arrhythmias and cardiogenic shock and even cardiac arrest. Unfortunately, some of what we do know about COVID moving forward is based on autopsy findings, the microvascular changes. There seems to be the hypercoagulability piece and the venous thromboembolic events. So not just PEs with hypoxemia, but also cardiac events. So again, certainly some earlier work that's come out, but again, coming from the American emergency medicine kind of lens around COVID data. The American Cardiology also came out with some recommendations specifically looking at risks in terms of acute PCI and CABG, in terms of trying to limit exposure of our health personnel and our OR personnel. Many organizations, UHN, where we work included, put into place high-risk procedures for intubation and resuscitation. UHN developed a special code called Code Delta. This is what we put into place for kind of notifying in-house the need for urgent advanced airway management. And then we could limit who was in the room. And then we were bringing in anesthesia supported by anesthesia assistants and respiratory therapists to ensure that we could minimize risk to our colleagues, and also looking at the risk to, aerosolization exposure. Some of the requirements around personal protective devices, and thinking about anybody who's had to work a 12-hour shift or be on call, working with a mask and a face shield and protective eyewear and protective clothing. I saw the nurses firsthand and the physicians where I work at the Toronto Western Hospital, and just what they went through kind of wearing PPE day in and day out, the skin breakdown on faces, the fatigue. We talk about virtual fatigue, but I think mask fatigue and PPE fatigue was a very real phenomenon during COVID. And the last thing I kind of want to intentionally pause on is the mental health piece. I think people are starting to look at this, and we know that healthcare professionals are exposed to trauma. We're dealing often with death and dying, supporting families and patients at end of life. People are often hopeful, coming sometimes from a small community hospital to a large teaching center, and expecting the best, and sometimes we don't have anything more to offer. The Center for Mental Health and Addiction in Toronto, the CAMH, has developed a really robust resource for mental health and COVID, looking specifically at healthcare workers. So if you're providing direct patient care, there is true vicarious trauma. I think about my colleagues and those of you who have experienced this firsthand, worrying about sleeping in their garage. There was a trailer dealership that was renting RVs for free to healthcare providers so they didn't have to go home and put their families at risk. Many physicians and nursing colleagues I talked to would come through a garage in their house or however they got into their home, drop their whatever they were wearing into the laundry, jump in the shower, and were self-isolating because of the concern with, risk to their family members and anybody in their their social distancing but bubble who may have been more at risk. Quarantine and self-isolation links with both of these phenomenons that people experience with COVID of increased depression, increased domestic abuse, and sadly even increased child abuse. So things that I think are huge to be kind of considering. I would encourage people to start those conversations and certainly look to some of the resources that are available, because we have to care for ourselves while we're also caring for others. So again, the CAMH has an excellent website, and that's again available to people. If you Google Center for Mental Health and Addiction and put in COVID, lots of resources there. I'm also very impressed. The Canadian Nursing Association has really done a great job at kind of aligning resources with people. And in my own province, the Registered Nursing Association of Ontario have done a lot of work around COVID and supporting healthcare professionals. This slide, a little bit of information, but I think it really speaks to what happened in Ontario. So this is kind of taking some of the practice guidelines and research and looking at what actually happened for us in Ontario. Core Health is our provincial STEMI registry, and they've compared 2020 in the darker line with the higher line you see at the top for 2019. Some key points on the graph are when the pandemic was declared on March 11th, when we started to ramp down, so non-essential services and things like, including, non-urgent angiography, elective CABG, and things, very much slowed down. Many of our cath lab nurses were redeployed when things did ramp down in our cardiac areas. And if you look at then moving towards closure of non-essential businesses, basically when we shut down in Ontario, again, the dates may be more variable going across the country, but a very significant drop in people coming to hospital. The activation of the Stemetry Register dropped by 25%, not insequential in terms of what this means for long-term morbidity and mortality. How many patients presented late with STEMIs or didn't come to hospital for fear of contracting COVID? How many of patients waiting for bypass surgery were afraid to come to hospital when they started to have symptoms of acute coronary syndrome? And I think this data collection and certainly looking at longer term outcomes of this will be so important to be looking at when we look at the impact COVID is having right now, but what are some of the long-term impacts? So not insequential numbers, and this is just Ontario, just in a few months of our experience. And certainly when I've talked with other people across the country, I think this probably mirrors what people may have experienced in the other provinces. And when I talked with a colleague who is a researcher based in London, and she's part of the ESC research group looking at COVID and cardiovascular treatment, they saw a very similar thing with people not coming to hospital or not seeking out healthcare in the same timely manner for things like acute coronary syndrome, unstable angina, or STEMI. So clinically significant when you look at this data. Okay. Close to home, so where Lindsay and I work, just looking at our actual COVID numbers. Since January 2020, we've had 334 inpatients that were positive for COVID. All patients who required ICU level 3 care or mechanical ventilation were managed only at the Toronto General MedSurg ICU and at the Toronto Western sites. We do have cardiac surgery and cardiac intensive care units, but we tried to house people again in those 2 units. From staff, so our healthcare professionals, there were over 7,000 tests done, and we had 128 staff become positive with COVID with a rate of about 1.8%. Slightly higher incidence on our COVID floors and on our medical floors, especially looking at some of the cohorting we tried to do to manage the care for these patients. So STEMI management at UHN in Toronto. At this point, I'm going to hand over to Lindsay, who's going to kind of take us through the rest of our presentation. She's going to kind of bring the lens of what she experienced as a coronary ICU nurse and also has a cardiac cath lab background. So I'm going to hand over to Lindsay at this point, who's going to be joining us in our presentation. So Lindsay, when you're ready, please join us and I will change your slides for you.
Okay, great. Thank you, Brenda. Hello, everyone. So as Brenda has mentioned, we are a major referral center for transplant and ECMO. We did have a contingency plan if our medical surgical ICU at TGH was full. The overflow was going to be COVID patients being housed in CVICU and such forth, just like other centers have created contingency plans. Thankfully, during the first wave, we did not need to utilize that. We will yet to see what happens during the second wave. So our STEMI management that requires emergent intervention was not directly halted during COVID. We did have a decrease in numbers, as Brenda had mentioned, not only in our STEMI patients, but also in our heart function patients. One of our doctors has reported a drop in 40% of admissions of those patients. So it's really unknown the effects that COVID will have an impact on our cardiac patients, just like Brenda had mentioned. So next slide. So like I said, the effects of the pandemic on our cardiac patients are unknown. It'll be interesting to see what comes of that. It's important for us to see the 12-lead ECG. The 12-lead ECG can provide a range of findings that can mimic acute coronary syndrome. And with the effects of COVID-19 on myocarditis or inflammation, cardiac inflammation, ECG abnormalities such as nonspecific T-wave ST segment changes, T-wave inversion, AV conduction issues, as well as PR segment ST segment deviations, both depression and elevation, need to be understood when defining whether or not it's a STEMI versus myocarditis. Okay, next slide. So since the STEMI management wasn't halted, our leadership team at UHN devised a plan, not only to protect our patients, but to protect the staff as well. And these protocols followed the ACC COVID clinical recommendations that Brenda had mentioned in the beginning, and is in line with some of our GTA centers, with the cardiac centers within GTA. So bottom line is, when a patient would present from EMS to our unit, due to pre-revascularization, the risk of a patient arresting, and during an arrest with CPR and intubation, those are all aerosolized generating medical procedures, and the risks are greater for the staff contracting something. So all staff pre-procedure would don an N95 with their PPE. So there is a dedicated nurse that's a STEMI nurse, so they would receive the patient with PPE, including N95, so that includes gloves, gowns, face shield, and bonnet, inside the room. And the patient is placed on droplet and contact precautions while under investigation for COVID. All of our persons under investigation, or PUIs, remain on isolation until we get a negative COVID swab. Unfortunately, during this time, all of those patients, since they're on isolation and until their swab comes back negative, they are not allowed visitors as well. So this is quite challenging sometimes, especially with our STEMI patient, for not only the patient, but their family members as well. And of course, our IPAC team are very involved in all of our COVID patients or isolated patients, and they're the ones that review the patients clinically and decide whether or not to take the patients off both droplet and contact precautions. Okay, next slide. So pre-procedure, the leadership team devised this just to minimize risk and spread. So we would have a second team. So the initial primary nurse would be caring for the patient inside the room with the N95 and PPE. They would, when the cath lab team was ready, called over, because of course they're out of house on off hours. So the second team, including a nurse and PCA, would then don PPE, including an N95, because there's still risk of arresting pre-revascularization. And so then the primary nurse would doff his or her PPE inside the room and accompany the patient over to the cath lab in order to give transfer accountability. And the cath lab team would be ready and waiting with their PPE, including an N95. Post-procedure, the CCU nurse would then retrieve the patient, so they would don clean PPE that can be a regular face mask, since the risk of arresting post-revascularization has decreased. So a team would retrieve the patient, and a person that is not wearing PPE would then lead the way to be able to open up doors to keep infection to a minimum. So then the team would retrieve the patient back to CCU. The retrieval team would doff inside the patient's room, and the primary nurse would don clean PPE and look after the patient. The next slide. So here's a case study of a patient that we knew, we were notified that of a positive test. He was a 62-year-old gentleman who was feeling unwell, went and got a COVID swab. It came back positive. After feeling unwell for about a week and a half, he developed severe chest pain with diaphoresis. He called 911, so EMS was activated on the scene. They did a 12-lead ECG, found that it fits the guidelines of activating a code STEMI. They give us a call to our direct STEMI line, their dispatch, who notified us of the positive test. His past medical history included hypertension, elevated BMI, and he was also an ex-smoker. Next slide. So here's his ECG. He presents, you can see he's a little tachycardic. There is ST elevations inferiorly by the blue lines or arrows you can see, ST elevations in lead 2, 3 AVF. There's also some ST depression in some lateral leads as well as V2. So in lead 1 AVL and V2, there's some ST depression. So the cath lab team was ready and awaiting. He received aspirin 160 by EMS, and in our unit, we inserted a second IV, repeated the 12-lead ECG, administered ticagrelor 180 milligrams, and gave him heparin 5,000 units IV bolus, and he was whisked off to the cath lab. The next slide. So he was found to be an inferior STEMI. He had a 100% mid-RCA occlusion. And so he received primary angioplasty through that RCA with one drug-eluting stent. Unfortunately, he had poor flow distally, and he was in a hypercoagulable state. He had platelets that were over 5,000. He required integralin, which is a glycoprotein 2B3A inhibitor for a period post-procedure. Also, unfortunately, distally to the stent in the very small vessel had clot in it that was not viable. It could not retrieve. So he had persistent ST changes. He was transported up to the medical surgical ICU where one of our coronary ICU nurses looked after the patient. He had persistent chest pain and ST elevation intra and post until his infarct completed. And he received IV nitroglycerin as well as hydromorphone for the pain. He was then re-swabbed in hospital and was found to have a negative result. So they're not really sure whether or not this was a COVID related or if the initial positive test was just due to viral shedding. Next slide. So he subsequently was treated, discharged home, did well, and is being managed by one of our cardiologists. And this slide goes as a shout out to all the interprofessional team members that play a part in taking care of all of our patients, not just our STEMI patients, especially during these crazy times. So next slide. Any questions? And thank you.
That was great. Thank you, ladies. And so we have about 2 minutes. So I see there is a question or two. So let me. Anyone aware of the status of cardiac patients that have been affected by the outbreaks at the Foothills and Calgary department? It seems that we would be at high risk for complications, or is the study of those patients ongoing? And I suspect it's ongoing, but let me defer to Lindsay and Brenda.
When the ESC reached out to Canadian centers, there are a number of trials going on across Canada looking at this data specifically. I know there currently is active research going on where we are at University Health Network, and I am quite sure that there are certainly research across the country. I think this is unlike anything we've ever experienced, and I think it's just now kind of people kind of catching their breath as our numbers unfortunately start to go up and really looking at this. But I know there are ongoing trials out west. I know there's stuff going on in the Western provinces, along with what's happening in, certainly for us in Toronto and Ontario, and there is work also being done in Quebec. And just again, a shout out to our Quebecs in Montreal, because they now are certainly dealing with, again, active COVID patients and a certain upsurge in their numbers. So no one likes to say it, but I do wonder about the second wave phenomenon. But I know there is ongoing research, and I think we're in that wait and see period because we don't know what will be coming next for these types of patients. So yeah.
Lovely presentation. Thank you, ladies. The reality is upon us, and scary, scary, scary stuff. And so this brings us to our get up and move kind of portion of our presentation or portion of our conference. And so each of you would have received, if you checked your mail, a tea bag in the mail. And so now is an opportunity for you to stand up and stretch. And I'm going to give you about 3 minutes to go steep a lovely cup of tea or obtain a breath. Thank you. Roseanne is holding up her